Good evening, everyone, and welcome to this live webinar on cancer in women, jointly organized by the Apollo Proton Cancer Center and the Times of India. Today's topic of discussion will be gynecological and breast cancer. Some of the most common forms of cancer affecting women are known to be breast cancer and cervical cancer. Studies say that breast cancer accounts for over 25% of the cancer in women. Cervical cancer is reportedly the second most common form of cancer among women. We are joined by experts from Apollo Proton Care Center to talk about gynecological cancer, that is, cancer in reproductive organs in women, and also breast cancer. Joining me right now for this session is Dr. Kumar Gubbala. He's a senior consultant in surgical oncology at Apollo Proton Cancer Center. Dr. Gubbala specializes in the field of gynecological oncology and has been educated in some of the most renowned medical institutions in the world. He's adept at open, laparoscopic, and robotic gynecological oncological procedures and has performed many complex surgeries during his medical career. We're also being joined by Dr. Bhawna Sirohi. She's the lead medical oncologist at Apollo Proton Cancer Center. She's an experienced medical oncologist who has been in the field for over 25 years. She is an international senior consultant who specializes in the treatment of breast and gastrointestinal cancer. She comes with rich experience of having worked in leading oncology centers around the world. Thank you so much for joining us, Dr. Kumar and Dr. Bhavna.
Thank you for having us.
Thank you. Dr. Kumar, let me get to you first about cervical cancer. Cervical cancer is the second most common gynecological cancer, or second most common cancer which affects women. And it's the commonest gynecological cancer that affects women. Could you tell us what are the other reproductive organs that could be affected by cancer and how common are they?
The most commonest is cervical cancer, as you said, and the second most commonest is ovarian cancer in India, and the third is the endometrial cancer, which is the cancer from the lining of the womb. The cancers can occur in the entire reproductive system, right from the vulva, the vagina, the cervix, uterus, tubes, and ovaries. Among it is how we know that cervical cancer is the most prevalent, and it's around 16 per 100,000 in India, which is quite high. And then it counts to around almost nearly 16 to 18% of the total cancers in women in the country after the breast cancer. And ovarian cancer is around 6% of the total cancers in India among women.
Right. Dr. Bhavna, I wanted to understand from you, we are dealing with, we are talking about different forms of cancer in women. How does cancer affect a woman's quality of professional and personal life? And what are the most devastating consequences that you've noticed of cancer?
I think cancer affects every patient who's diagnosed with cancer. To begin with, is the first thing that goes through their mind is fear. And every single patient thinks about, is will I live? Will I be on the other side? And one thing I would like to say is that most of the patients that we see who are diagnosed with cancer will live, and majority of the cancers are easily treatable. Yes, there are some consequences, but most of those consequences are short-lived and reversible. It does have quite a lot of consequences on personal life. It could be emotional, physical, anxiety, depression, some of these that go through a patient's mind. Physically, there could be hair loss as a result of treatment. There is, patient have removal of the breast. A lot of body image issues can be there. Some patients also experience social isolation, and one thing that is, we live in a male-dominated society, especially in North India and the villages, and that itself. I mean, I had a patient who, as part of my rural screening, we diagnosed a patient with breast cancer just by a clinical exam, and it was like, the husband was like, who's going to look after the kids, who's going to do the labor, and So it's loss of daily wages, loss of it's financial toxicity. So all of these issues have a huge impact on the patient. Recently, I had a patient who'd been diagnosed with breast cancer and is going through a divorce after that. So some patients do go through devastating consequences as a result of the diagnosis. But I would say majority of the patients do get a lot of support from their family and their spouses.
Right, Dr. Kumar, what has been your experiences on that front? Do women receive the kind of support that is necessary while dealing with cancer?
Majoritarily, yes. But when it comes to fertility preserving options, you show them brighter sides of having children, having more sexual life, and then having to preserve the organs will give them a bit of extra more insight into things. And obviously, not all the time. We see it depends completely on the background you're coming from, how well you're educated are, how you're going to support the family, how your economic status of the family is, or what you wanted from a relationship. These are very important. But we tend to, as clinicians, become member of the family and then tend to bind them together. And we do our bits to keep relationships together as such, trying to get whatever we can for the patients as in the support is needed.
Right. How can we identify cancer, breast cancer early on? Experts always stress on screening and early detection. What are the symptoms that one should watch out for early on, and how early do they manifest in people?
So I think one thing I always stress about is that for every woman and also men, they should know what is normal for them, because breast cancer can affect males also. So it is important that one knows what is normal. You should know what your normal breast feels like. If you're standing in front of the mirror, one breast may be larger than the other. Look at what the contour is, if there is any lump, reddening, swelling, or any puckering of the nipple or inversion of the nipple, or if you see a swelling near the collarbone or under the arm. So there is a 3-finger test one can do, of examining the breast, where you start from the line under the arm and then just go around the contour of the breast and, divide the breast in 4 quadrants and feel the breast with 3 fingers in all the 4 quadrants and the central part as well. So if you feel any lumps, you see a physician and get it checked out. That may be completely something that you don't need to worry about. It may be a benign lump, which is a fibroadenoma. Again, you need to then examine yourself maybe once a month to see if it is increasing in size or it has remained stable. Usually, we don't need to do anything with a fibroadenoma. So be self-aware or be breast aware. That is very important. And then screening. Most of the centers all around the country in the cities have a preventive health program. One should become part of that. Apollo has a fantastic pro health program where just for general health checkup, and they have a specific cancer screening related module which looks after cancers which lend themselves to screening. And cancers that lend themselves to screening are the ones that you can detect in precancerous stages, which we call stage 0. So for breast cancer, it is ductal carcinoma in situ, so which is detected with a mammogram, which is a simple X-ray of the breast, which should start at the age of 50 years annually, but you can start it from the age of 45 as well. And if there is a strong family history of breast cancer or ovarian cancer, then you may have to start screening a decade before your loved one was diagnosed. For colon cancer, you can have a stool occult blood test by fecal immunochemical method. It's important that you are spending money. It's healthcare you are doing it. That you try and find the right place to have the test done. Just don't go to any preventive health program. I would say have the right test. That's very important. So self-educate yourself. The third cancer which lends itself to screening is cervical cancer, where you can detect cervical intraepithelial neoplasia, and you can treat it at the same sitting that you detect it. And the fourth cancer is head and neck cancers. If you have any ulcer or a sore that does not heal, there is whitening or reddening in your mouth, especially if you chew tobacco, you must get that checked out.
Right. Dr. Kumar, are there any, so at what age are women normally susceptible to gynecological cancers? And are there any common symptoms that you can point out for us, to identify gynecological cancers?
Cervical cancer, especially, is around 40s. It's more common. So it depends. And then endometrial cancers are the most commonest among women who's gone through menopause. Same with ovarian cancer as well. So the screening program is for cervical cancers and usually starts around 25 to 30. If you're having a smear test done, which is every 3 years, then you have to start screening at 25. There's something called a co-test, which is the national recommendation where there are facilities with good resources, where you get the co-test is checking for the human papillomavirus, which is 90% of the times the cause for cervical cancer, and then doing a smear test together. And then you get it every 5 years. You started at 30 if you're getting a co-test, then it goes up to 65. Women don't get screened for endometrial cancers. It's very symptomatic cancer. The only woman who gets screened is somebody who's got a family history of endometrial cancers, where there's something called a Lynch syndrome, which they're actually prone to. These are the women who get into a screening program. They need to be screened and want to retain uterus. And within which the other family members might have had a colon cancer, ovarian cancer, stomach cancer. It's got multiple cancers in it. So, and especially for screening for ovarian cancer, we do it only for someone who's got a very strong family history and there's a mutation. But not all family histories will have mutation. At the same time, all mutations are not related to family history as well. So you see 40 and 60 of it. So somebody in your family has got a BRCA mutation and is diagnosed with ovarian cancer. These are the people who we actually benefit from screening program. How we do it is 6 monthly blood test, look at the tumor markers in the blood, and then ultrasound scan.
Right. Doctor, sorry.
I would want if there's any input from Dr. Sirohi.
No, I agree with you, Kumar. That's very well said.
Yes, I wanted to understand the risk factors for gynecological cancer as well as breast cancer also. So let me start with Dr. Kumar first. Are there any lifestyle, changes that one could adopt to prevent cancer or prevent or delay the onset of cancer at all? And what are the risk factors in general for cancer in women?
We'll talk about the most commonest one, which is the cervical cancer, which most of the times, 90% of the times, is caused by human papillomavirus, which is present in 90% of the women who are sexually active. And the first thing is early sexual intercourse at early age, having multiple sexual partners, not using barrier contraception in the form of condoms so that no viral infection happens, and using oral contraceptive pills. You think it's purely for contraception, but then you're more prone to seeing someone else. So it gets you to more risk of seeing new set of organisms. And smoking itself is carcinogenic, and then it decreases the immune system. So if these factors are modifiable in these circumstances, then the incidence of cervical cancer would come down. And coming to endometrial cancer, it's more common among obese women. It's 2 times more common with someone who's got a BMI of between 25 to 30, 3 times between 30 to 35, and 4 times between 35 to 40, and it's 9 times more common among somebody who's got a BMI of more than 40. So good diet, exercise, bariatric surgery, there's ways around it you can manage so that your risk of developing endometrial cancer comes down. Hypertension, diabetes, heart disease, everything falls down. You get a better life if you're keeping away from all these things altogether. But there's not much modifiable risk what you could do in ovarian cancer as such.
Right. What about in breast cancer, Dr. Bhawna?
So in breast cancer, I usually divide them into, where the evidence is linked to lifestyle related, which you can modify, which you can't modify, evidence which is not very clear, and something that has been disproven. So I'll start with the evidence, which was controversial and disproven, because some books do talk about it, and it's about antiperspirants and wearing bras. And because the thinking was, it obstructs the lymph flow, so it increases the risk of breast cancer. So that is completely not the case. So you can use antiperspirants and you should wear a bra. Then some studies which we are unclear, we don't know, we are still learning, is vitamins. There's linked, high fat. Some studies have found a possible link. So one should not actually pop vitamin pills right, left, and center. You should. In fact, there was a study in breast cancer patients which showed that patients who took a lot of supplements did worse than those who did not take. So make sure you discuss it with your physician. So some studies have found that diets high in fruits and vegetables and calcium-rich dairy products, but low in red and processed meats also might lower the risk of breast cancer. But this also remains an active area of research. One should, I feel, have a good prebiotic and a probiotic diet. Prebiotic means you should have a lot of fibers in your diet. Probiotic, the right kind of bacteria, which is, with yogurt and all this. It's very important. Also, a study found that diets in Asian countries like ours, and especially Japan, Korea, high in soy products lower the breast cancer risk, because the incidence of breast cancer here is less compared to the West. It's 1 in 5 ladies in the West develop breast cancer compared to 1 in 25 in urban India. So, but I think our incidence is rising and is matching the West because of lifestyle related factors. And with that, the major risk factors which we can easily mitigate, because just avoid doing them, like maintain a healthy weight, exercise at least 30 minutes daily, something that gets your heart rate up and makes you sweat. So walking is an activity, I say. So it is not exercise. Exercise is something which will make your heart rate go up. Avoid alcohol and smoking. I mean, again, lifestyle, not having kids is a very personal decision, but that increases your risk for breast cancer. Breastfeeding for at least 6 months, but the recommendation is for a year. If you're using oral contraceptive pill or a hormone replacement therapy, discuss with your physician and try and use an estrogen-only pill and for a shorter duration. Also, breast implants, especially the textured ones, increase the risk of lymphoma. So if you're planning to have that, discuss this as well. The risk factors which you can do nothing about is, having an early periods, having a late menopause after the age of 55, being taller, having dense breasts, inheriting some genes, being a lady and getting older. There's nothing we can do about that. So I think these are the factors. The lifestyle factors are the ones which are common across all cancers, I would say. Gynecological, breast, GI, everything. And they're very easily doable, actually, with some amount of discipline.
Right. Dr. Kumar, many women are known to be suffering from PCOS. It's a very common condition that is being discussed these days. Is PCOS a potential risk for endometrial cancer?
Yes,
or
it
any
is.
other form of gynecological cancer as well?
No, it's purely for endometrial cancer, and I'm afraid I've not told you earlier that it's one of those modifiable risks where you need to have withdrawal bleedings if you're diagnosed with a PCOS. What happens with PCOS is women don't have regular periods; they have irregularly placed periods. They don't ovulate, so they release one of the hormones when you ovulate, and then that shreds the lining of the womb, and that's how a period happens. So if this doesn't happen, there's a continuous stimulus of one of the hormones called estrogen. So that keeps increasing the thickness of the lining of the womb. At one point, increased stimuli will make it abnormal. More and more will become what we call it hyperplasia, and then more stimuli will make it abnormal. Then it becomes changes within the cells, and then they develop into cancer. What we normally recommend women is, if there's anything modifiable in the PCOS, like the BMI is high and greater than 25, we ask them to reduce the weight. At least cutting down weight by 1/6 would get most of those periods normal. And most of very common recommendation we tell everyone who's diagnosed with PCOS is to have a withdrawal bleed. What we do is give hormones to have periods every 4 months. That will decrease the risk of having endometrial cancer. but there is no other risk to any other gynecological malignancies as such. It doesn't increase risk of ovarian cancer or any other cancer.
Right. Dr. Bhavna, what are the common challenges, when it comes to women in rural areas, especially? What are the challenges that they face when it comes to awareness of screening and treatment options when it comes to cancer, breast cancer especially?
So I think in rural areas, access is a major issue. Most of the cancer centers that we have are in metropolitan cities. There are some cancer centers which are coming up in second-tier cities. I have spent a lot of time in the villages in UP, Rajasthan, Haryana, and Karnataka. And I have worked with at least in UP, I've worked with the ASHA and Anganwadi workers. And when I came back from London in 2009 for the first time, I spent a lot of time with them, training them into early signs of cancer. And also I tried to do a CAP study, knowledge, attitude, practices, in about 37 villages in Uttar Pradesh. And what we found out that the use of tobacco was rampant. A lot of people used it, and it started from a very young age, the use of tobacco. The factors, the good thing about rural the women was that they were slim, they were fit, they were active, and they were happy. So, always whenever you met anyone, they'd come for a clinical breast exam. So it took me a long while to convince them to actually come for an exam, because I had to speak to the Gram Pradhan, get a lot of people involved to get them to come and have a clinical breast exam and also have a pap smear done. So the awareness is not there. And I think I always feel that rather than creating a parallel system, NGO and everything, we need to work with the system that we currently have. And we have a fantastic system of healthcare workers in the villages with ASHA and Anganwadi workers. We need to empower them. They go to everybody's house to give, the vaccine, the oral polio, the immunization. So that is an amazing opportunity for them to talk about cancer and, talk about the early signs of cancer. So what I did was, in fact, I trained my sister-in-law who lives in the village to give the same lectures that I used to be giving to ASHA and Anganwadi workers, and to train in early signs of cancer. So the other thing I realized was a lot of chilies being used and no fruits and vegetables. People would be living on potatoes and chapatis. And so again, this is something, having milk in a village in Thamblau, I realized that the kids wouldn't even have milk. They're very vitamin deficient. So there are simple things which one can do as part of education, just having a banana, they would have the thing, but they'd be selling them, most of it. So simple things that we can do of increasing awareness. A lot of challenges, mainly to do with finances and access, I think. So the huge parity of cancer care in India has been, and I have seen it myself. I've gone to a village in Maharashtra, Dearpan as well, with one of my colleagues from Tata. What we saw was the early cancers are made incurable by treatment given locally by non-oncologists. So very important point is the cancer should be treated by cancer specialists. At least the surgery would be, you have to follow the principles of cancer surgery. If you're, removing a bit of colon, you have to remove a minimum number of lymph nodes, let's say 12 lymph nodes. So these are standards which are set, and you can only get the treatment of cancer right the first time. So it is very important that the cancer surgery is done by a cancer surgeon at a specialist center. Because if you don't do that, you are denying the patient a chance of cure. The patient will not be cured. His cancer will recur in 3 months, 6 months. It will be incurable, and the cost of treatment will be very high. So that's the parity, that patients are treated, the early cancers are treated locally. They never come to the specialist centers, but at the same time, patients with advanced cancers or incurable cancers are referred on, for palliative care. So I think this is something which we need to change. And I think the best way of doing that is by empowering the patients, by talking to you.
Thank you. Dr. Kumar, would you like to add on to that a little bit? What is the scene as far as gynecological cancers are concerned among rural women? You know, do they have enough awareness? Do they have access to screening techniques? What is the scene regarding that?
I don't think there's access to healthcare provision in the rural setting to diagnose cancers, but I think things are moving on and getting implemented. But most of the women I see with cervical cancer are from a low socioeconomic background, who's had no access to screening, vaccination, or treatment. So usually present late as well. They leave the symptoms in for a long time until it hits them very hard. That's when they usually come in and see. But urban population, they come for screening, they even come for prevention, and they get their early treatment. That's the difference I see actually when it comes to cervical cancers. But ovarian cancers, they usually present very advanced. There's not much of a difference between urban or rural population as such. And endometrial cancers, they're usually symptomatic, and then women usually present, but there is late presentation when compared to uh, rural and urban population, because diagnosis, presentation, getting it checked out.
Well, since this session is more about, you know, gynecological and breast cancer, could you also throw some light on what are the screening facilities available as far as gynecological cancers are concerned?
Mostly it's cervical cancer. The screening program is set to detect it very early, or look for precancerous changes, or to see whether there's any high risk that somebody is going to develop any abnormal changes within the future. The way it works out is, as I previously mentioned, if you're getting a smear test done, what happens with the smear test is you take cells from the neck of the womb, look it up under the microscope, see whether they're normal or abnormal. Okay, if they're abnormal, then you need to get a colposcopic examination, which is using a magnifying lens and using special stains like acetic acid or iodine to see whether there's any precancerous changes or cancerous changes. If there's any precancerous changes that way, you can have a treatment then and there. And that sort of cures 95 to 98% of the precancerous changes. And then they go back to the normal routine screening. So that way, screening is well set. There's something called co-testing, where you do a screening test with smear test, and then look for the high-risk human papillomavirus, which are the most commonest ones, is the 16 and 18. And then if there's high risk, then you get a colposcopy examination set, and then you get the treatment then and there. That's how it actually prevents things from moving on from precancerous changes to cancerous changes. And that gets the numbers down for cervical cancer. But there's no screening program for endometrial cancer. We screen women who's got a strong family history only for ovarian cancer.
Right. Dr. Bhavna, is there a chance of cancer spreading to other sites if not detected early? And what are some of the adverse consequences that you've noticed among the patients that you have examined?
So any cancer, if it is detected in early stages, by that I mean in stage 1, 2, and 3, is curable. And is the cost of treatment is also very low if the cancer is detected early. Cancer, if it is not treated on time, can spread to other areas. So the whole point of treating early cancers as soon as possible through a multidisciplinary team working, which includes a surgeon, radiation, and a medical oncologist, is that we increase the cure rate so that the cancer does not spread. Once it has spread to other sites, it becomes a stage 4 cancer. Now, for breast cancer, again, there are a lot of treatment options available, even if it is a stage 4 breast cancer. It can spread to any organ of the body. So the way the cancer spreads is by two means. It spreads by lymphatics. So if it's from the breast, if it goes to the lymph nodes in the underarm or the axilla, it usually becomes stage 3. But if it goes through the blood, blood goes everywhere. So, it can spread to lungs, liver, brain, anywhere. So then it becomes stage 4. But like I said, in patients, if they have in breast cancer, we classify as hormone responsive, HER2 positive, and triple negative. So I've had patients with hormone responsive breast cancer who've been on hormone therapy for a very long time, 15 years, 20 years as well. So just being diagnosed with stage 4 breast cancer is not all doom and gloom. There are a lot of treatment options available for all these 3 types of breast cancer.
Right. What about gynecological cancers, Dr. Kumar? Are there any chances of them spreading? And
Yes.
what are the adverse effects that it could have?
The adverse effects of any spread is you don't have much life left beyond you if it's gone. And if it's very advanced, like stage 3 or 4 cancers. Very early cancers, we say the first time we use the word, you be cured. But when it goes beyond very early stages, then we just keep you in remission. That's what we say, keeping the cancer away for a longer time. So you usually follow them up for like 5 to 10 years, depending on what stage they present. Usually 3 and 4, they usually recover back very fast. When it comes to cervical cancers, early cancers, 96, 97 in stage 1, you can keep them away for, that's the usual data that's available, saying that they could be kept away for 5 years, 96, 97% of the times. But it gets to 2, 3, that's where the survival numbers come into play. Then they come to like 50, 60 to 70% 5-year survival, then it drops to 50, and stage 4 gets up to 5 to 20%. So it's like your spread is telling you that you're not going to live longer, but you'll not be able to cure most of the times. You're just going to keep it away from longer time. Similar thing with any endometrial cancer or ovarian cancer is the same. But unfortunately, cervical cancer in India and ovarian cancer as such in general in any part of the world or anywhere usually come up very advanced. Very few women I could operate early cervical cancers, and usually when they come in, it's fairly very much advanced actually. But ovarian cancer usually presents late. 3/4 of them present at a very advanced stage. But we here as a specialist center, we offer one of the best results in the country. Any intention, wherever you go, you get the same chemotherapy, same regimen or change in regimen. There's a usual protocol what people have to follow, but expertise does help in changing, looking into things when you have expert medical oncologists. But surgery makes so much of a difference. The intention of the operation is not to leave any cancer, at the same time not compromising the quality of life of a woman. So when you hit the things together, then you get more survival. But we achieve it in 90% of the women here in this institute, and which maybe is the best numbers in the world, not compromising the quality of life and with less complications. They are very long operations. They can take from 6 to 8, 8 to 10, or 12 to 14 hours. It's the passion that drives, it's the commitment for the patient we have drives in, and we are a subspecialists in it, and I've got special interest in it. This is what you need when you treat women with ovarian cancer. See, look, extra few hours of my life is giving somebody a few extra years is something what you have it in mind. That what pushes us much beyond and takes us an extra mile to deliver the treatment. So that's how it is. But we deliver one of the best treatments in the country here, maybe in the world.
Right. Doctor, on that note, I also wanted to understand how has the field of surgical oncology evolved over the years as far as cancer treatment, especially gynecological cancer, is concerned? What are some of the latest techniques available, surgically to remove cancer right now?
First thing is we could give options because we are dealing about reproductive system and cancers in reproductive health. Every woman wants to have a child. That's their completeness for being a woman. So we give options if it's detected very early for women to have children, which we call it fertility preserving options. So that's available in cervical cancer. If it's presented very early, then we take the neck of the womb with tissues around it and a bit of the vagina, and then hook up the vagina to the womb, and then they can have babies in the future. That's one. In the same way with any changes within the endometrial cancer, we do that. We treat it with hormones and put a hormone releasing coil that revert back the changes that's happened to normal. Same thing with ovarian cancer. If it's presented early, if it's confined to one ovary, we could take that ovary out and then look at other areas that's not spread, and then preserve the womb and the other ovary and tube so that they could have babies in the future. That's fertility preserving options as such. So we do, some things have evolved with surgical paradigm as well, being more aggressive for ovarian cancer. Previously, what used to be said was optimal. Operation was leaving a cancer around a centimeter was considered optimal, but now it is not. It's a complete site reduction, which means taking all the cancer out, which not visible to the naked eye, and not doing any damage to the woman. That way means it's not that it's spread everywhere, you go take it out everywhere. What's feasible to do it, what could be done, has to be done that way. And even advanced endometrial cancers were treated only with chemotherapy and all, but now being more radical in taking whatever the cancer is spread. And then same way, with cervical cancer, if somebody is recurred after radiotherapy and chemotherapy, there are surgical procedures we do to give them more life. Now, the latest advances are robotics and minimally invasive surgery. The last 10 to 15 years, we moved on from traditional open surgeries in cervical cancer and endometrial cancer to laparoscopy, which is minimally invasive surgery. And now in the last 5 to 10 years, it's robotic platform. So we use only little cuts like less than a centimeter and deliver the specimen vaginally. We do most of the operations, taking the tubes, uterus, tubes, ovaries, and the lymph glands out, which is the most commonest place if there's any cancer from the lining of the womb or the cervix. So that helps women to recover faster. They leave the hospital the very next day, and they're back to life in a week's time. And this reduces complications from the operation, and then the better quality of life with lesser complications. And these are the few advances we had.
Right, Dr. Bhavna, there's been data to show that a lot of younger women are getting affected by breast cancer these days. It is no longer like only women above 40 years of age are susceptible to cancer anymore. No, a lot of young working professionals are getting cancer. What do you find are the factors that are influencing this, and how can it be mitigated?
So I think you're absolutely right, Pratibha. I'm seeing more and more younger women with breast cancer. In fact, globally, we've created a group for young women with breast cancer where we meet every 2 years and discuss how to make sure that the treatment is effective. And because when young women are diagnosed, they are at the most productive period of their life as far as career is concerned, as far as planning a family, planning children, marriage. So a lot of dynamics come into treating them. So we feel that they deserve special attention. Dr. Kumar talked about oncofertility. So in younger women, the chances of the breast cancer being genetic is also higher. So that issue also has to be looked at. What we are also doing as part of oncofertility is if a lady does have BRCA gene, we also can do tests to see that she does not pass it into her offspring, which is called pre-implantation genetic diagnosis. So there are a lot of complexities of care. Psychological support is very important. Why this is happening, and more so in India because we have a younger population, are for any cancer, the cancers are diagnosed a decade earlier in India, mainly because our population matrix is like that. Also, I think there has been a lot of urbanization. And with urbanization, what has come is, yes, the per capita income has increased. So the lifestyle has also changed. It has become more sedentary. We are prioritizing our careers. So we are marrying late, and we're having lesser number of children. And if we do have children, we want to get back to work quickly because we do not want to miss on a promotion, or want our career on the right track. So we would breastfeed for a shorter period of time, not the recommended 6 months or 1 year. And so, I mean, in UK, I mean, the fantastic maternity health support, my friends would take leave for 6 months to a year, but my friends in US, I mean, they would only get 4 weeks leave for breast, after having a child. So all of these dynamics are very, very important because they increase the risk of breast cancer. I'm not saying that the lady would definitely get it, but these are some of the factors which are increasing the risk. And the other thing is, I feel in younger women, misdiagnosis is quite common because they keep going and seeing a specialist or their physicians with some or the other problem. And I've had patients who've been referred for psychological support, thinking that they need psychological help because they keep coming with some breast pain. And I think key thing is in UK, like I've said before, that if a young woman has come with an issue with a breast problem, a second or third time, she gets onto the expedited 2-week referral pathway to see a breast surgeon. So I think this is what we should do. We should not ignore. Maybe consider in a young woman doing an MRI breast. Again, MRI breast should be done in a place which has the MRI machine, which is easy, but it should have the breast coil as well, because then the image quality would be better, and ideally should be read by a breast radiologist.
Right. Dr. Kumar, is it possible for a woman, post-surgery to have their sexual functions completely restored? Can they lead a normal sex life, once they get treated for cancer?
We'll start with each cancer as such first, but coming to cervical cancer, what happens with the operation is we take what we call a radical hysterectomy. It's different to a hysterectomy, what normally is done. Radical hysterectomy is to take the uterus out with tissues around it and top of the vagina. So with these type of operations, there's always a tiny risk that you could damage the nerves that's going around them, which actually supplies the bladder, the bowel, and the vagina. So looking at these and to be very careful not damaging this is very important. And that will not affect a bladder function, sexual function, and the bowel function. So you need to have specialists doing these, and it's not very easy to see them. It took a long time for me to get trained and to know where they actually are and do it. I've been trained 6 years of fellowship. So it took a long time. Even now, if I want to do it after 9 years of practice, I could hit it in 8 on 10 or maybe 7 on 10, but I usually know where not to harm them. So you tend not to see them all the time, but not to harm them, it's very important though, but that's what retains sexual function in women. But more importantly, we even take the top of the vagina by a centimeter, at least a centimeter, up to 2 centimeters. It's a very forgiving organ, it stretches, but there's not much of a problem when it comes to sexual life as such. But what happens with other modalities of treatment in cervical cancer is woman gets chemoradiotherapy until it's not very farly advanced as such, and they might get radiation to the top of the vagina. When these radiation-induced damage happens to the vagina, it burns. It's a very sensitive tissue as such. It burns them out a bit. And then what happens, there's a tiny bit of a burns after radiation, they just get tend to adhere together. So what every woman needs to go through is what we usually give them is vaginal dilators post-radiotherapy. And they have to be very religious with it that they use it. Otherwise, they can't retain their function as such. And if they have their ovaries taken out or there's a radiation-induced damage to the ovaries, we tend to give them more advice how to get a better sexual life, like giving creams that might rejuvenate the vaginal tissue, and then maybe using lubricants during sexual activity. These are actually very important as such post-radiation. And I strictly have a strict protocol what they need to do it that will help them to retain their sexual functions. And with ovarian cancer, not much of a damage to any of these problems, but ovaries are taken out and you lose the hormonal function that's being delivered for the vagina. Then they'll have vaginal dryness. Same thing with the endometrial cancer. They are very hormone receptor, which means you have to take the ovaries out as well. So you lose ovaries when you're diagnosed with endometrial cancer or ovarian cancer, but you may not lose them when it comes to cervical cancer. So that way, what we give is something, a plant replacement product, which has shown to be a benefit, which we call phytoestrogens, that might help them. That's evening primrose oil tablets and some of the other tablets, which could just get them menopausal symptoms. These are psychiatric medications, but helps vaginal hot flushes, mood disturbances, and all together. So making sure the sexual function is retained.
Right. Dr. Bhavna, I wanted to ask you about the treatment of cancer, treatment modalities in cancer as such. What are the roles of chemotherapy and radiotherapy in the treatment of cancer, and at what stages are they recommended?
So I think the first thing is the diagnosis. Once we have diagnosed that the patient has cancer, we would do staging. And with staging, we would check if the cancer has spread anywhere. Stage 1 is when it is confined. Let's say for breast cancer, it's confined to the breast and it is less than 2 centimeter in size. So majority of these patients will be cured with surgery alone. If they've had breast conserving surgery, they would need radiotherapy. And if they have hormone receptor positive, they will need tablets, which they need to take for 5 years or 10 years. But if it is a big, larger cancer, if it is, they may need chemotherapy or may not need chemotherapy. And, doing some of these genomic tests can guide us whether the patient will need chemotherapy or not. For stage 3 cancer, very likely they will need chemotherapy and radiotherapy. So for local treatment, if a patient has breast conserving surgery, they definitely need radiotherapy. I've had some patients who have actually opted for removal of the breast or mastectomy to avoid radiotherapy. But again, the caveat there is if any of the lymph nodes that are removed from under the arm are positive, then despite a mastectomy, they will need radiotherapy. So this is quite complex decision making that goes as part of our multidisciplinary team meeting process, where we discuss every patient post surgery to discuss and optimize what treatment they need. And like I said, it's in most situations it's black and white. We are very clear as to what should be recommended to the patient, and then we have a shared decision making with the patient to see. So I've had patients where we've said the benefit of chemo is about just 4%, and they've said yes, I will take it. And I'll say out of 100 women we treat, only 4 will benefit, and they'll say I will take it. I've had patients where I said the benefit of chemo is 20%, 30%, and they would say no, I don't want to take it. So it's a patient choice. And because you can never say that there's guarantee if you had chemo or radiation that it'll never come back. Possibly the patient is cured with surgery alone. But what we try and do all of these strategies to decrease the risk of cancer coming back, because when it comes back, it is usually incurable. And it's quite distressing and devastating for the patients to know that the cancer is not curable. But even at that point, I always tell patients that even though it is not curable, it is easily treatable. So I think at the Apollo Proton Center, one of the things that drove me to here was the site-specific oncology, and it's a pleasure to work with colleagues like Dr. Kumar, because I feel that was my vision for cancer care in private practice in India, is that to drive academics and research and also site-specific oncology. Because 80% of cancer care in India, almost I would say 70 to 80%, is delivered in the private sector. So it's very, very important that we drive excellence here, and we're doing this at the Apollo Proton with doing clinical management teams like you have in Tata Hospital disease management groups, where we have a radiation oncologist, medical and surgeon who only treat that type of cancer, and they specialize in that type of cancer. Like I do not see any other cancer other than breast and GI.
Doctor, I also wanted to ask you: do these treatments lower the immunity levels of the patient, and how do you manage it?
So surgery and radiotherapy usually would not lower the immunity of the patient. But yes, chemotherapy and some form of immunotherapy and targeted therapy can lower the immunity of the system. Because the white cells that we have in our body, especially the neutrophils, are the first responders to infection that will eat up the bacteria, fungus, or any other germs that we have. So chemotherapy can affect the white cells because bone marrow is a fast dividing organ in our body, and chemotherapy acts on fast dividing cells. So it can affect the white blood cells, but again, we can mitigate that, by giving patients growth factors. So what we tell patients to manage this is, have enough rest, have a healthy diet, exercise, and reduce stress as much as they can, and be proactive, have a continuous dialogue with their oncologist or their nurse specialist.
Right. Dr. Kumar, coming to gynecological cancers, is it possible for women who have received treatment for gynecological cancers to have normal fertility levels? Can they get pregnant? Can they have children? Is it possible? Is it also possible if they have been detected at any stage of cancer?
It is only possible when women are detected at very early stages. It's very difficult to preserve the fertility when they're detected late stages. We can preserve fertility in cervical cancer in what we call it's a stage 1, but even that within the stage 1, the size of the cancer has to be less than 2 centimeters. But if it's between 2 and 4, there's a trial going on to see whether there's any way that woman would benefit, but it needs more evidence to come in. So anything less than 2 centimeters, not gone beyond the neck of the womb, yes, you can preserve fertility and woman could have babies. The results are almost similar to a typical radical hysterectomy, how I've said earlier, where you take the uterus out with tissues around it with the top of the vagina. But there's slightly increased chance that they could have babies in the miscarriages in the second trimester. But they have to, the only way they could have the delivery is by cesarean section, that too with an up and down cut. That is with cervical cancer. Coming to endometrial cancers, that is early as well. That has to be very early stage and has to be a low grade. Cancers are graded by the aggression they are. So there has to be low grade, they shouldn't be very aggressive cancers. They have to confine only to the lining of the womb or precancerous changes. They can have fertility preserving options. What we do is give them hormonal tablets at the same time, put a coil in which releases hormones, and then the changes would revert back to normal. And with ovarian cancer, it's still an early stage. If it's confined to one ovary, yes, you could preserve the other ovary and the womb, and then woman could have babies and fertility could be preserved. One other way, when we can't do all these things, if there's especially in cervical cancers, we could hook up the ovaries, but they don't preserve the fertility. But what we could do is stimulate the ovaries, take the eggs out and preserve them. Or we could just preserve the ovarian tissue and stimulate it at a later date. But hormonal function could be preserved by keeping them off from the pelvis and putting out into the sides of the abdomen where they could still have the hormonal function. Usually cervical cancers are not hormone driven. So you could use the hormonal function and fertility function, but they have to use someone else's womb. That's called surrogacy, where you take the eggs out with stimulation and then that you could still have, woman could have babies, but in another's womb. That's called surrogacy.
Right, Dr. Bhawna, what about in breast cancer? Women who are affected by breast cancer, in case they are pregnant, can they give birth to their babies? Can the fetus be preserved in case they've just gotten pregnant? And what about breastfeeding women? Women who have just delivered. Yes.
I would just go with breast cancer during pregnancy. So
yes.
Again, we know much more about this than we did, say, 20 years ago. Developing breast cancer during pregnancy is not an indication for termination of pregnancy. In fact, we have followed babies who've had treatment while the patient was pregnant to up to 18 years, and that has shown that the children do not develop cancer and they do not have any cognitive or any other side effects relating to the chemotherapy. Chemotherapy is safe to give. Some drugs are safe to give in the second and third trimester of pregnancy. There are some treatments we would not give during pregnancy, like hormone therapy, targeted therapy, and radiotherapy. We reserve them to when the patient has had a baby at full term. So we try and hold the hand of the patient till she reaches full term, delivers the baby, and then do other treatments. But we can give chemotherapy safely in the second and third trimester. As far as breastfeeding is concerned, again, we had a lot of discussion at our meeting for breast cancer in young women on this. From the breast that had received radiotherapy and surgery, probably not. But from the other breast, the patient can breastfeed, but not during chemotherapy. It's not recommended during chemotherapy.
Right.
Adding to that, Pratibha, gynecological cancers could be given chemotherapy during pregnancy. And I've delivered a baby a couple of months ago. Somebody is actually recurred. She had ovarian cancer on one side, had fertility preserving option, then recurred the cancer when she was pregnant and had chemotherapy, delivered the baby, and an operation during pregnancy as well. She had an operation for a recurrence in pregnancy and chemotherapy, and then had a baby delivered. So you can give chemotherapy in pregnancy, but with close monitoring of the baby and the mother, making sure both are well. We obviously want a well mummy to look after a good baby.
Right. That's very heartening to know. Dr. Bhavna, you've had like about 25 years of experience in this field. I'm sure you would have come across a variety of cases here. What has been most intriguing or interesting? What are some of the most interesting cases that you still remember? Any anecdotes that you can tell us?
So I think it is for me, I always say this, that from every patient you learn something. And and the trust they put in us inspires us to do better. And I'm always inspired by, I had a patient who would not give up even a single day's work. She was a principal of a school, continued working through. I even said, the kids are quite young, the risk of infection. Probably you should avoid it for the first few cycles. And but I think her sheer will. So I think I learned so much despite having all the other issues that surround all of us, with kids, with parents, with families, and then to have a diagnosis and to cope with it so well, continue working as well and looking after everything. I think hats off to women, the way they cope and the way they rally around their family and take things forward. So I think I find this very inspiring. I used to treat a type of blood cancer, myeloma, and at those days, people said that it's only 6 months that you would live. Had another patient, I still remember, and he'd come to my clinic and been told that you have 6 months to live, and he'd just chosen somebody to get married to, and both of them from Banaras came and met me in the clinic, and the patient had a type of leukemia against which we had a drug. And today that patient is very happily married, is a fantastic artist. I did a art for life to raise money for poor patients in Tata Hospital, and he contributed his art as well. So he has completely blossomed. He has his family. He still continues to take the drug. He has CML. He's taking imatinib, and doing very well. So what I feel is that if you feel that what you the diagnosis that you've been given and the prognosis you've been given may be correct by the oncologist, but take a second opinion if this is something that is so life changing that you've been told that you have 6 months to live. So I mean, he's still there. We follow each other on Instagram and Twitter, and still stay in touch.
Nice. Dr. Kumar, what can be done to raise awareness, increase the level of awareness about cervical cancer and other forms of gynecological cancer in India?
First, it should be nation-driven, and then maybe a government policy would help, and then making sure that it hits to the root level, right from the village level to the cities. I think it should come up from the government when it is, and then making sure that it's getting implemented as such, and then educating children at very early age, and then youngsters, how they could be prevented, how cancers, what are the risk factors, what are modifiable risk factors as such, and then media. And then maybe like what you're doing now at the moment is very useful to create awareness. That will reduce the cancer, even if it goes to few and then it goes to few others through the mouth. It is still you're trying to help you. I'll be very happy when most of the viewers who's done this would at least have the children to have HPV vaccines, or their relatives to have it, or most commonly if it's within a low socioeconomic community where there's no access to healthcare at all, would help prevent 70 to 80% of the cervical cancers. And it has to be a screening program, nationally driven, with strict protocols in it. I worked in the UK. I was there for 15 years. and the incidence is almost 2 to 3 per 100,000. And in India, it's around 20 per 100,000, which is quite high. And these numbers were actually reduced because there's a strict national screening program. Another thing to the other side of it, to the Western world, is most countries have free healthcare in Europe. So that is helpful as well. Maybe getting free access to certain areas would help prevent these cancers. But trust me, I think the amount of money we spend or the family spend is much more, I'd say, when it comes to an instance of 125,000 per year. Would be much lesser in preventing it. I think it should be a driven program from the government, maybe.
Right. Dr. Bhavna, I have one more question for you before we take questions from the audiences. Uh, uh, we all know about the example of Angelina Jolie. Whatever she did, although it was a personal choice, it did a lot to create awareness about breast cancer, and what could be done to prevent it, up to a certain extent. Do we have any relatable role models like that in India? And will it be helpful if celebrities like that, come out and speak about their personal experiences of having dealt with breast cancer?
So I think two role models I can think of. I mean, I did something with Manisha Koirala. I think she's a wonderful advocate. Then you have Yuvraj Singh, who's after having his treatment, he came back and is playing cricket and got back to a normal life. Kylie Minogue is there for breast cancer. She went back to singing and completely leading a normal quality of life after having been through all the treatments in her country. So I think talking about it is very important. And I would just say that whoever's listening, yes, you've listened, you can be disciplined and do screening and do it for your family members as well. But for people around you, encourage them to undergo screening, which will detect cancers early. Because the whole point is we have to focus as a country on prevention and early diagnosis. Only then, I mean, our 5-year survival rates are so. I mean, it's very disheartening to see that for breast cancer, where 5-year survival is more than 90% in the West, it's about 60% in India. And within India, there are huge disparities. It's about 25 to 30% in Northeast India. I think that should not be the case. We have to change this. And the only way we can change it is if all of us talk about it, and encourage everybody around us to take part in screening programs.
Right. Doctor, we'll just take a few questions from the audiences right now. I have a question from Priya. Do we see any connection is there any connection between cancer and geography?
Yeah, I mean, in UK we learned that, but just in India, if you look at the National Cancer Registry report, it came out this year. So again, India is a country with small countries inside. You have a low income group, you have a low middle income group, you have a high income group, and the cancers that are there are completely different. On the Ganges belt, we have gallbladder cancer, which is very common. In North India and Northeast India and South India, stomach cancer is very common, stomach and esophageal cancer. And I think that is related to our dietary patterns as well. The incidence of rectal cancer is going up in Delhi, Goa, in all the metropolitan cities. The incidence of breast cancer is going up as well. So yes, I think the incidence of cancer in Northeast is very high. And I think the government and Tata Trusts, a few others are making efforts to have care accessible to those areas.
Right, Dr. Kumar, would you like to add on to it?
I'd agree with Dr. Bhawna.
All right. So I go on to the next question. It's about food habits. Different food habits like rice intake in the south and wheat in the north. It is said to increase the risk of cancer. Is that correct?
No, I don't think the grains are linked to cancer. I think you should eat grains.
Not in gynae cancers. Diet has not been
There is no link to it.
in gynae cancers at all, other than endometrial cancer if you're obese and then you're eating too much.
Yeah. Okay. So obesity has to be watched.
Yes.
Yeah, yeah.
All right. Vaibhav has this question. Recently, we've read a lot about how during the COVID-19 lockdown, many people have been suffering from depression due to the change in their lifestyles. In that case, given the drastic changes, how does a cancer patient cope with this? Will they need therapy or care, extra care, to deal with depression?
So I think cancer patients have really, it's been very hard for them. It's been hard for everyone around, I agree. But very hard for them because, when lockdown happened, to keep our patients safe, what we did was, in daycare, I said we would allow to begin with no attendance to decrease the footfall. And then we said one attendant allowed. All of these, I had a patient I remember in Delhi, we had a 1.5 hour consultation after her diagnosis. She'd just been told she had breast cancer, and at the end of it she says, can I hug you? And it was such a it was very difficult for me to pull back, but I did hug. And then it's very hard. It's a very emotional disease. It affects you mentally, emotionally, psychologically, physically, in every single way. So I think psychological support is something which we do offer to all our patients, and I think we should talk more about it, because in India we do not do that often. And but I think you are absolutely right. Patients do need more psychological support because it's tougher on them, and also they are more vulnerable to catch COVID infection as well. And I've had patients where they've been isolated because of COVID, not being able to be in touch with anyone, and also going through chemotherapy and treatment. So it is quite hard.
Dr. Kumar, would you like to share your observations on the same?
The one thing I'd tell you is it took a while for some patients during COVID. They've come to the hospitals pretty late. If they had symptoms somewhere in March, April, and by the time, some of them could be very aggressive cancers, and they've presented late, and then the treatment changes completely. If they were operable, they become inoperable, and they get additional modalities of treatment, and their survival completely depends on whether if it's confined to the organ or gone beyond the organ. So that we have seen during COVID quite a bit, because it's 6-7 months with aggressive cancers is a lot of time.
But patients have been very resilient and absolutely amazing. I mean, I've had patients who they've worn a shield, gloves, everything, and they've come, had the chemo, gone home. When I was in Delhi, they crossed borders, 2 borders to come and have chemotherapy, got the permissions done. And it's the same here as well in Chennai. And so I think we must really admire I think you get the strength somehow to deal with whatever problem you're facing with.
Right. Doctor, I have another question about screening. We have already discussed this, but there is a question about it. Shobna Balu asked, do you suggest women to have screening after a certain age? If so, from when should they be conscious about this? I would like both of you to answer that, because
Let Dr. Bhawna talk about breast, and then I talk about cervix.
Sure.
So for breast, the recommendation is from the age of 45, you have a digital mammogram. Between 40 and 45, you can have, like I said, a digital mammogram with a digital breast tomosynthesis every 2 years. But after 45, you can have a digital mammogram once a year as part of screening.
With cervical cancer, for sexually active women, we usually recommend the screening to start around 25 to 30 years. If it's a smear test, it has to be done every 3 years until 50, and then every 5 years thereon. If there's something called co-test, which is used to identify the high-risk human papillomavirus, and a smear test, we recommend it every 5 years until they hit 65.
Okay. Doctor, another question from Miss Libby Thomas. She asks, today you find more women smoking, drinking, and they have other such habits, especially urban women. Has this trend increased the incidence of cancer in women?
I think so, because these are two very important factors. I mean, I show slides when I give my prevention talks, the incidence with each unit of alcohol goes up by 10%. And same with smoking as well. It increases the risk of not just breast cancer, but colon, cervix, bladder. And I just can't understand how and why people would do that. So yeah, I think that is one of the factors as well.
Right. Dr. Kumar, would you like to add to it?
Lifestyle issues with regard to gynecologic cancers is cervical cancer. Smoking increases the incidence of cervical cancer.
Okay.
But there's no relation to alcohol or anything with any of these other cancers.
To alcohol. All right. Okay. So another question is on IVF. In the recent days, many women go for IVF treatment for infertility. Do they stand a chance of getting cancer because of this?
There's a little evidence saying that stimulated ovaries are at a higher risk of developing ovarian cancer, but it's not fully as known.
Okay. Another question we have is on food supplements, especially protein supplements. Are food supplements and protein supplements safe? Many of these supplements are said to cause cancer. Is this true?
So again, anything I would not, if there is enough fresh, I would suggest, have fresh vegetables, fruit, something that is locally grown. So, eat things that are local, you're not flying millions of miles to get it, so something which is preservative free. So if you're having protein, it would have some preservatives, it would be processed. So I would avoid processed food or anything which has artificial sweeteners, artificial stuff in it, because we know that, it increases the risk of cancers.
Right. I have a question from Raja Rajan, who asks, what has been your most challenging assignment so far and how did it affect you? Dr. Bhawna, would you like to go first, and then I'll take Dr. Kumar's view on this.
So this is, I'm assuming that it's about patients. I think the one thing which I find very challenging and very emotional still, after having been in oncology for so many years, is the end of life discussions as part of palliative care, which I think as an oncologist it is our duty to do that. And also to talk about prognosis, because a patient may have a wish that they would want to fulfill. So I had this patient who hadn't seen his grandchildren for 2 years, and the son who was here was very keen that I don't tell the prognosis. The patient was very keen that he somehow got hold of me and said, I really want to know, and I explained it to him. So he got his grandchildren to come from US and meet him. I had another patient who wanted to do this cruise on the Nile. She had cancer in the brain, and we tried to figure out how we do that, because it was a risk to get her to do that, and but somehow we managed that. She did the cruise on the Nile. So I think it's very important to have these end of life discussions with our patients, because they may have a wish or a desire or to do something that they've always wanted to do, or set their affairs in order for the family. And I always find it very difficult, very emotional, and do not resuscitate is illegal in India, sadly. So we cannot do that as well. So a lot of times patients end up in ICUs of hospital where they're not able to see their loved ones. They're not able to have their Ganga Jal or listen to Gita or see their priest. So all of these things, I think holistic needs assessment, I call it, needs to be done for patients who are at that stage. And we do have patients who are at that stage, and I think we should address that head on. rather than not talking about it.
Right, Dr. Kumar, what has been your most challenging experience in your career?
Every day itself is very challenging for us. We always wanted to throw out light for patients who walks into the room, but we obviously would not be able to in every aspect. So I would want a situation where we'll be able to help them all the time, but it's difficult, like how Dr. Bhawna said about palliation. So these are not very easy. You have to look at every perspective, patient's perspective, family perspective, how you have to get their journey till the end of life much safer, and how comfortable you could make them. These are very important things. Even with the diagnosis as well, it's shocking for many. So every day is a bit of a challenge for us. And then how we want to help them is very important. And then it's always there at the back of our mind. We want to give everybody a good news, but it doesn't happen, right? So every time it just puts us as a challenge. So every consultation is at a challenge. It's different level. So what expectations are from the patients, diagnosis, how we'll be able to help. And certainly other situation where you're helpless, you wouldn't be able to do anything. That's when palliation comes into play. These are the most difficult times we have in the clinic. And we just get ourselves involved a bit with them. Otherwise, we don't feel their pain. So that's how we move on.
All right, Doctor, I have another question which is sounds a little technical to me. This is from Nandini Rajendran. She asks, any suggestion on leupride injection to prevent fibroids after open myomectomy?
That's not related to cancer as such, but it's what it does is decreases the hormones within the body and then dries it up so that the fibroids doesn't come back again. So these helps for benign gynecology, but it doesn't increase cancer risk at all.
Okay.
But it gives somebody go through a menopausal-like symptoms.
All right. One final question I have is about what kind of food items should we avoid while cooking, to avoid the risk of cancer?
So what kind of
food items?
So again, I had an amazing dietitian. I think you can look it up on my YouTube channel. I hope somebody's posted it on diet and cancer, where she talks about, she's done a lot of research on it, and about not using saturated fats.
Okay.
So anything that sets, and again, there's two schools of thought on it. Things that set, ghee sets, coconut oil sets. So her thinking is, use like say cold pressed mustard oil or olive oil, things that don't set. So they are unsaturated fatty acids. So these would be safer. But then you have another school of thought which says ghee is actually very good. So I think I'm not an expert in this. I would suggest use vegetable oils. Don't use refined oils. Use cold pressed vegetable oils, something that is local to you. We cook in mustard oil, cold pressed.
Okay. Dr. Kumar, I have a question for you. Why is it important for women with gynecological cancer to see a specialist in that particular area?
Dealing with organ-specific specialists is very important, because it's like going to a generalist and a specialist. You have special attention, you have special ways of treating. People know, I don't spend any other time treating other cancers. This is the only cancer I treat. And then you have update yourself, you have more evidence, latest research, what are the new treatment modalities you have. And then we here as a group, I don't treat by myself. We sit together in a tumor board, 10 of us, the oncologists, the radiation oncologists, the pathologists, radiologists. These are all subspecialized, like how Dr. Bhawna does breast and GI. We have pathologists doing gynae and radiologists looking at most of we have subspecialists. You get that extra edge beyond. Most of the general things wouldn't matter, but when it goes beyond that line, that's when it matters. It's only one chance everybody's got to live. So you have to get it right. So that's the way is like seeing a specialist. And then nothing beyond us is there when you're coming to a subspecialist. Nothing wrong should happen. Most of the decisions what we make here can be challenged anywhere in the world. So that's how we tend to be very, very overcautious. give whatever is possible on planet Earth, and then get them right. And then coming to a gynecological oncologist, I care for women right from menarche to menopause. I've trained in it. I know how to care for them during pregnancy, what the values of pregnancy are, what the values of womanness are. So you get all that sexual life, sexual aspects. You come and see me, and then you see generalists. It's very different. So you get all the package when you come in, because these are very important as well. So you get a completeness when you come and see someone who is specialized in it rather than a bit of it. So that's the advantage you get. You see somebody who's subspecialized.
Right.
Is there anything, Dr. Bhawna, you want to add?
Yes, yes.
So, I mean, like I said, when in UK, there were people who did everything. That was, I mean, I think 3 decades ago, medical oncologists, surgical oncologists. But over the years with service reconfiguration, we've learned that to improve survival, to improve outcomes, to have the best outcomes, you need to be site specific. I mean, I cannot keep up with the research in GI, and GI is 12 cancers, GI cancers. And to keep up to date, I'm going to go home and log into this meeting that's happening in UK for UK Breast Cancer Group for learning about breast cancer. And so we have to keep up to date. I feel we have a commitment to our patients to deliver the best care. And why can't we do it in India? I mean, we have amazing brains, amazing resources, and I think we should do it. And site-specific oncology is being done in places like Tata and AIMS. And I think we have to drive it in the private sector as well. And truly, I mean, hands on heart, I think Apollo Proton is the only center doing it. And I think it will filter down hopefully to the other Apollo cancer centers as well. And this will help us improve outcomes and 5-year survival for our patients.
And one other thing to add on, Pratibha, is when things were in transition, when moving from specialty to subspecialty, the data was pulled up and looked into, and then patients had better survivals and better treatments and better quality of life, or whatever you call, with a subspecialist than with a specialist. So there is a lot of data supporting that you get better. Yes.
And plus, the other thing, we have to have transparency and accountability in our systems. Like in UK, I remember if a colorectal surgeon is not removing, say, 12 minimum number of lymph nodes. So if I see the patient, if the patient has 10 lymph nodes removed, I would end up giving chemotherapy. But, if they've had 12 lymph nodes removed or more than 12 and all are negative, the patient would avoid chemotherapy. So it has such a huge implication on the patient's cure rate. And the Daily Mail named and shamed the surgeons, and they were sent for retraining so that, they do this. So I think we have to audit our data. We have to publish. We have to be transparent, and only the patients can help us drive this. That's why we need to empower the patients so that they question the doctors.
Right. Thank you. Before we wrap up this session, I would want to take one final comment from each of you. What can be done to increase the awareness about cancer in women in India? And what is your final comment? What do you want to say to the women who are logged into this session? Let me go with you first, Dr. Kumar. What is your final advice to everybody who's watching this session?
Couple of things, because the most common is cervical cancer. Get vaccinated if you've never been sexually active. Get your near ones and dear ones vaccinated, the children as well. That's the first important thing. That would get the incidence down by so much in a few years down the line. Second thing is get onto a screening program, please. That would help the cancer reduce by 85%. So you could get it treated when there's precancerous changes. So that will, what the numbers we're looking at is around 125,000 new cases every year. We will not be looking at the same numbers if news spreads to everyone in few years down the line. These are two important things I would convey, actually. I'll leave to Dr. Bhawna to maybe tell
Dr. Bhawna.
breast cancer.
So I just want to say that that don't let the fear of COVID stop you from coming to the hospital to get screening done, or seeking advice for any ailment that you have, because we have tried to make the hospitals as safe as possible. So, and the other thing is, prioritize yourself, be proactive, look after your health, because if you are healthy, you can look after your family, your parents, and everybody else. And if you are not healthy, if you're diagnosed with late stage cancer, then everything falls into place. Because I think a woman in a family is the rock that holds everything together.
Right. Thank you so much for that, Dr. Bhawna and Dr. Kumar. You've been very patient in answering all the questions today. Dr. Bhawna, I know you've had a really long day. Thank you so much for taking out time to, join us on this very lively, at the same time informative webinar session on the cancer that affects women, and helping us to, spread awareness at least a little bit among women about what could possibly ail them. So thank you so much for that. I hope to have more such informative sessions with you all in the future as well. Thank you so much.
Thank you so much, Pratibha. Thank you.
Thank you, Pratibha.
Thank you. Bye-bye. Bye. And thank you, Times of India.